What are the updates? The carcinoma, ovarian carcinoma, is morphologically, immunohistochemically, and molecularly, more importantly, molecularly, mainly 5 types: low-grade serous, high-grade serous, endometrioid, clear cell, and mucinous carcinomas. The incidences of them, if you see, high-grade serous is the most common. And you may be wondering why mucinous carcinoma is only 3 to 4%. Now, predominantly mucinous carcinoma in the ovary are metastatic. They are either from the appendix or from the GI tract or from some other organs, gallbladder and biliary system. Okay, that's why primary mucinous ovarian tumor are only 3 to 4%. That you have to remember. What is the origin for these tumors? Low-grade serous tumors are arising from endosalpingiosis or from fallopian tube. High-grade serous carcinoma, 99% they arise from the fallopian tube. Both endometrioid and clear cell carcinomas are arising from endometriosis. And mucinous carcinoma, we don't know where they are arising from. And studies are indicating they may be arising from teratoma, the mucinous epithelium in the teratoma. What are the precursors? This is very, very important because the precursors helps you to make the diagnosis, and these precursors are also known as field effect. When you see a serous tumor with serous cystadenoma or serous borderline tumor, you have to think of low-grade serous carcinoma. Whereas high-grade serous carcinoma, not like in any other organ arising from low-grade serous. High-grade serous is arising from stick, that is the tubal intraepithelial carcinoma. Okay, serous tubal intraepithelial carcinoma, that you have to remember. Please remember, high-grade serous carcinoma is not arising from low-grade serous carcinoma. They are two different animals. We will see it in a minute. In endometrioid and clear cell arises from atypical endometrioid, atypical clear cell ovarian tumor, or borderline ovarian tumors of endometrioid or clear type respectively. And mucinous tumors arises from mucinous borderline ovarian tumors. What are the cancer syndromes they are associated with? The high-grade serous carcinoma is associated with BRCA1 and 2 hereditary breast and ovarian carcinoma syndrome. The endometrioid and clear cell are associated with Lynch. That's why whenever you see endometrioid or clear cell carcinoma, you have to screen the patient for Lynch syndrome by molecularly and immunohistochemically, and you have to go for colonoscopy. Mucinous carcinoma and low-grade serous carcinoma are not associated with any hereditary syndrome today. Tomorrow it may change, who knows? Molecular. This is very, very important for these 5 tumor types in the ovary. KRAS, the very important marker I am just going to concentrate. KRAS is mainly associated with low grade. High grade associated with the BRCA, because this is associated with the BRCA associated hereditary breast and ovarian syndrome, and TP53 and HRD. The endometrioid carcinoma is associated with beta-catenin, PIK3A, PTEN, KRAS, lot of them. Okay, but you see, because of the Lynch syndrome relationship, they are having MSI, and POLE also very important thing recently coming into endometrioid. This is all these are also involved in endometrioid carcinoma of the endometrium. You have to remember. Clear cell carcinoma mainly associated with ARID1A. And mucinous carcinoma is associated with CDKN2A and the KRAS. And lastly, this is the one I want all of you to pay attention. Why we have to split our hair in typing? Because of the treatment difference. Low-grade serous carcinoma are more responsive for MEK inhibitors, whereas PARP inhibitors and immune checkpoint inhibitors are more effective in high-grade serous carcinoma. The endometrioid serous carcinoma is more response to mTOR inhibitor and immune checkpoint. So immune checkpoint inhibitors and mTOR are associated with endometrioid. Clear cell, tyrosine kinase inhibitors and immune checkpoint inhibitors, and mucinous tumors, trastuzumab. These are all tongue twisters. Okay, and you are all very lucky. I got it in the first time, and I'm not going to try another time. So this treatment difference is there in all the types. That's why we have to type it carefully to give the best treatment to the patient. What is the IHC of major these 5 types of tumors? There is a panel of markers where you can do Paxate, WT1, P53, Napsin, and hormone receptors. The high-grade serous carcinoma, 98% associated with abnormal P53. The low-grade serous carcinoma, 100% they show WT1. The endometrioid carcinoma are showing hormone receptors. Clear cell carcinoma, interestingly, they are positive for napsin A. You all know adenocarcinoma of the lung is positive. For some unknown reasons, I don't know, or I have not checked the literature. You please check the literature why napsin A is positive in clear cell carcinoma. Mucinous carcinoma, no markers, but P53 is associated with mucinous carcinoma. The only other tumor that have a high P53 is high-grade serous. It's morphologically, it's very easy to differentiate. So what markers you give weightage depends upon morphology. Because please remember, HNE is the queen. Previously, I used to tell HNE is the king. Nowadays, kings are having no power, like in the chessboard. Queens are having all the power. So HNE is the queen. Immunohistochemistry is the king with less power. So when we talk about P53 mutant type, there are 3 patterns you have to remember. One, there is overexpression where more than 80% of the tumor cell nuclei, when Jacqueline explained it in the cervical lesions, more than 80%. This is the number you have to remember, where P53 is overexpressed because of the mutant form. Null expression, where complete absence with the retained internal controls. You can see some of the endothelial cells or inflammatory cells here and there. They are taking up the P53, whereas the tumor cells are negative. So this is null type. Or unequivocal cytoplasmic positivity. See the cytoplasmic positivity. It should not be seen in the cytoplasm. So these are all the 3 patterns which characterizes the mutant type P53 expression. Coming to serous tumors, remember I told you these are low grade and high grade are different animals. So low grade is like a cat, whereas high grade is a tiger. And the tiger never develops from the cat. I know they are from the same family, but cats won't go into tigers. That you have to remember. So as I told you before, the low grade serous carcinoma arises from serous histoadenoma or serous borderline tumor, whereas high grade serous carcinoma directly arises from stick. There is no low-grade component in high-grade serous carcinoma. What are the absolute terminologies? In serous tumors, atypical proliferative serous tumor of low malignant potential, semi-malignant serous tumors, non-invasive low-grade serous carcinoma, and micropapillary serous borderline tumor. They have all been removed and they are all replaced with a serous borderline tumor. And as you know, the high-grade serous carcinoma can arise from the fallopian tube, ovary, or tubo-ovarian or peritoneal origin. So they nicely have criteria now in the WHO 2020. If you want to tell this is arising from the fallopian tube, that should be stick or invasive high-grade serous carcinoma in the fallopian tube, or part of the entire length of the tube is inseparable from the ovarian mass, okay, where you cannot differentiate whether it is arising from the tube or ovary. Normal tubes are not seen. If you want to say the high-grade serous carcinoma is arising from the ovary, both fallopian tubes should be separate from the ovarian mass. No stick or mucosal high-grade serous carcinoma in tubes. Otherwise, tube should be free of the lesion. If you want to call tubo-ovarian, where the fallopian tubes and ovaries are not available for complete examination, and pathological findings are consistent with the extrauterine high-grade serous carcinoma. When do you want to call it is of peritoneal origin? Both tubes and ovaries are fully examined, completely embedded, and no gross or microscopic evidence of stick or HGSC in tubes or ovaries. These criteria are very, very important because none of the markers will help you to differentiate the primary site of the tumor, because these are all high-grade serous carcinomas. All the markers are positive despite the difference in the origin of the tumor. So clinical and radiological correlation is very, very essential to identify the origin of the high-grade serous carcinoma. There is another pattern in high-grade serous carcinoma known as set pattern, solid pseudoendometrioid and transitional like pattern. Okay, this is a solid pattern. These are glandular pattern that looks like proliferative endometrial glands. These are not endometrial glands, so that's why it is called pseudoendometrial. And this is more looking like a urothelial or transitional. This is the set pattern. And this set pattern is associated with homologous recombinant deficient or HRD deficient tumors, and they are usually associated with tumor infiltrating lymphocytes. And whenever there is an increased number of tumor infiltrating lymphocytes, they will respond to immune checkpoint inhibitors, because immune checkpoint inhibitors act on the lymphocytes. That's one of the concept you have to remember. Any tumor infiltrating lymphocyte in the tumor, immune checkpoint inhibitor will be useful. They will show geographic necrosis, high nuclear pleomorphism, and very brisk mitosis and apoptosis. And the presence of set pattern should be included in the pathology report, and the somatic testing for HRD should be done, because whether to use the PARP inhibitors is very, very essential. And they are more commonly related with BRCA1 or 2, and they are platinum sensitive tumors. And as I told you, immune checkpoint inhibitors will also be very, very useful. Coming to the updates in non-serous tumors, here you can see mucinous epithelium as well as serous epithelium. So this is a seromucinous tumor, and this is having infiltration on the ovarian stroma. So this is seromucinous carcinoma, and now it is known as endometrioid adenocarcinoma with mucinous differentiation. Terminologies not recommended in non-serous tumors are atypical proliferative tumor, tumor of low malignant potential of all epithelial tumors, mucinous, endometrioid, seromucinous, clear cell Brenner, no atypical or tumor of low malignant potential. They are all now called as borderline ovarian tumors. Coming to the new variants of this 2020, here you can see nice glands. Some of them are having tall columnar cells, some of them are having very flat cuboidal cells, some sclerosis is there, and more importantly, there is a colloid-like intraluminal secretions. Okay, this colloid-like intraluminal secretions is a clue for the diagnosis of mesonephric like adenocarcinoma, and you might be seeing it in the cervical. Mesonephron is just going parallel, starting from the cervix to the fallopian tube to the ovary. Okay, so mesonephric rest will be seen, mesonephric hyperplasia can be seen, and then it can develop into mesonephric like adenocarcinoma. Multiple architecture, as I told you, intraluminal eosinophilic colloid-like material is a very low power clue for that. Immunohistochemically, they are positive for GATA3, TTF1, CD10, and PAX8. Negative for hormone receptors, WT1 and wild type P53. Molecularly, they are more associated with KRAS mutation. And pathogenesis, they are arising, as I told you, from the para-ovarian mesonephric remnant or Mullerian carcinomas displaying secondary mesonephric transdifferentiation. You all know Mullerian or Wolffian are just parallel to each other, and Mullerian carcinoma may develop into Wolffian type transdifferentiation. We exactly don't know what is the pathogenesis. The next tumor, this is more looking like a solid epithelioid tumor, whereas here it is more well differentiated tumor. Okay, whenever you see any tumor well differentiated and poorly differentiated distinctly, you think of de-differentiated carcinoma. So it is a biphasic tumor with undifferentiated and well differentiated area. The well differentiated area are usually low grade endometrioid adenocarcinoma. You can see it is more like endometrioid adenocarcinoma. And sorry. So this is a de-differentiated carcinoma, and immunohistochemically the undifferentiated area, so loss of SMARC A4 or SMARC A2 or SMARC B1, and it shows wild type P53 and ARI ARID1A mutational changes. Okay, and the differentiated area may be positive for cytokeratin, but undifferentiated area is negative, and the loss of INI1 is very, very important for the diagnosis of de-differentiated carcinoma, but this can be diagnosed on HNE. Prognosis, these are associated with the advanced stage, pelvic and para-aortic lymph node, and they have a very poor prognosis. This is another entity where you see the clear cells here and then endometrioid carcinoma. You might have guessed it, it is a mixed carcinoma. At least two tumor types should be clearly distinguishable with the distinct morphological and preferably immunophenotypic differences. And each histiotype percentage should be reported, known in minimum percentage. Okay, even if you see 95% endometrioid with 5% clear cell, you put it as mixed carcinoma, 95% endometrioid ovarian tumor with 5% clear cell carcinoma. Okay, usually they are related with endometriosis associated histiotypes, and the most common combination or mixed carcinoma is the endometrioid and clear cell carcinoma. Coming to carcinosarcoma, it's again a biphasic high-grade carcinomatous and sarcomatous element. But as I told you, these sarcomatous element are metaplastic or metaplastically arising from carcinomatous tumor. So now it is considered as variant of carcinoma, not a mixed epithelial mesenchymal tumor. Coming to the last portion of the talk, sex cord stromal tumors. More than 90% of adult granulosa cell tumor are associated with somatic FOXL2 mutation. This is very, very important. And this picture nicely tells you in normal cell growth, the FOXL2, GATA4 and SMD3, they are the complex, and they act on the targeted gene, and they have less apoptosis and less cell survival and more apoptosis. They maintain the balance and they lead to normal cell growth. But whenever there is a mutation of FOXL2, the target genes are affected, and they lead to imbalance between apoptosis and cell survival, and that leads to malignant growth. Please remember FOXL2, and immunohistochemically IHC stainings are available, and FOXL2 is very, very specific for sex cord, predominantly adult granulosa cell tumor. And this I already told, mutation affects the balance between apoptosis and cell proliferation. Cerebral cell tumor, there are three molecular types: DICER1 mutant, FOXL2 mutant, and DICER1 and FOXL2 wild. The DICER1 mutant cerebral cell tumor arises in the young people, and they present with androgenic symptoms, okay, and male-like features. And morphologically, they are more moderately or poorly differentiated with retiform or heterologous pattern. This is very, very important because the retiform pattern associated with the DICER1 mutation, whereas FOXL2 and DICER1 and FOXL2 wild doesn't have, they lack the retiform. The FOXL2 arises in the old people, postmenopausal, and it is present with estrogenic symptoms, whereas the DICER1 is with androgenic symptoms. And the last one, wild type, is intermediate age, and they are more well differentiated, but they also lack the retiform. And this picture, thanks to Jazzopath in Twitter, and Twitter is a very, very useful social media where you can learn a lot of pathology. For example, this is a beautiful tweet that covers the whole molecular subtypes of sertoli cell. It's a DICER1 with the retiform pattern, FOXL2 with more poorly differentiated, and DICER1 FOXL2 wild type more well differentiated. So, and as I told you before, this is young people with androgenic, postmenopausal with estrogenic. This is another tumor where you see a lot of cystic spaces surrounded by solid nests of cells and then bands of fibrosis. This is the triad. This tumor characteristically have this triad: cystic spaces, solid nests, and bands of fibrosis. And interestingly, they are strongly positive for beta-catenin, which is present in the cytoplasm as well as the nucleus. The name of the tumor is microcystic stromal tumor. And because of the beta-catenin, you all might have guessed it, this is associated with familial adenomatous polyposis. As I told you, cystic spaces, hypercellular areas, band-like fibrosis, and the cells are positive for beta-catenin and sex cord stromal cell markers like inhibin or steroidogenic factor 1. And that's why these are stromal tumors and microcystic stromal tumors. And APC gene or beta-catenin gene mutation is there. This is a part of the extracolonic familial adenomatous polyposis. So all these patients should be screened for APC gene, and colonoscopy should be done, and the family members also should be screened. You have to remember that. This is another variant, you might have guessed it. A lot of apoptotic bodies, small blue cells, and this is a small cell carcinoma with hypercalcemia, and they are associated with a lot of loss of SMARCA4. Okay, this is SMARCA4. Only the endothelial cells and inflammatory cells are positive, whereas the tumor cells are negative. So SMARCA4 and hypercalcemia and small cell morphology clinches this diagnosis. This is another tumor where you see bands of fibrosis and two patterns. Sorry for the, it's not a very clear picture. Here it shows a more sex called sertoli cell tumor, whereas here it looks more granulosa cell tumor. So this is GYN andro. Okay, so this is a GYN androblastoma. This is been reintroduced in 2020. In the previous edition, this terminology was removed, but now it is reintroduced. It is nothing but, as I told you, mixture of female and male elements. Most commonly is predominant sertoli cell tumor with a small juvenile granulosa cell tumor. So that brings to the conclusion of our discussion. How do you approach the ovarian tumors? First, see the cell of origin. Second, look at the cytological atypia. Third, look into the invasion. Depending upon that, the surface epithelial tumors are divided into whether they show cytological atypia. When the cytological atypia is absent, invasion is absent, the impression is benign. When there is cytological atypia but it is low grade and no invasion, then it will become borderline. When there is a low grade cytological atypia and invasion present, then it will become low grade carcinoma. When there is a high grade cytological atypia without invasion, it is known as in situ carcinoma. When there is a high grade cytological atypia with the invasion, then it will become high grade carcinoma. Okay, so this concept is very, very important in the ovarian tumors. And coming to the updates, molecular changes, you have to keep on reading, and whatever you read, you practice. And whenever you are practicing, whenever you are seeing an interesting case, even if you know about it, read the recent literature. This is very, very important. And I forgot to mention, we had a tumor, or during our discussion we are talking about implants which are associated with serous carcinomas. We used to divide them into invasive and non-invasive. Non-invasive divided into desmoplastic and surface, and now the recent CAP indicated all invasive implants are metastatic low-grade serous carcinomas. Okay, that's very, very important. That's why whenever you are seeing a case, you read about it in the recent literature, because science is advancing. So reading and practicing and reading should go hand in hand. These are the beautiful references. One is the 5th edition WHO classification of female genital tract, and then you all should be knowing pathology outlines. They have monthly newsletters, and one of that newsletter from Gulisa from Canada and Ricardo from Chicago, they talked about what is new in gynecologic pathology, ovarian fallopian tubes in 2021. That's based on 2020 5th edition of WHO. And I got my hands on another very interesting paper. What is the new on ovarian carcinomas? Integrated morphological and molecular analysis following the new 2020 WHO classification from Antonio and his partners from Italy. And this is in the journal Diagnostics 2021. So that's the end of my discussion. Can we go to the polls, Aditya?
Yes, sir. Yes, sir.
So now it should be easy. So I think you quickly open the poll. You want just 1 minute for them to see it. What is this tumor? And this tumor is moved to endometrioid carcinoma. What is it? So do you have the poll open, Aditya?
Poll is open, so now majority have responded, and now they have shifted their allegiance to 80% to seromucinous carcinoma. It was earlier 54.
What was the 50 from 54? Now it is 84, is it?
Yes, sir.
Super. So this is seromucinous carcinoma. Here you can see, number 1, this is epithelial origin. Number 2, cytologically atypia present low grade. Number 3, it is invasive. Okay, it is having fallopian tube like and goblet cells, and mucin stain is positive. So it is seromucinous carcinoma. Now it has been moved into endometrioid carcinoma with mucinous differentiation. Question number 2, Aditya. This is the precursor lesion of what?
I think you all have seen this slide before. Take a close look at it, and I will launch the poll now. Closing the poll in 3 seconds. So before in the pre-poll, pre-presentation, it was 45% for high-grade serous carcinoma and 34% for low-grade. Now it is 54% for high-grade and 33% for low-grade. Pretty much the same still.
Still there in low grade. Come on, guys. I told you clearly the high grade. This is a fallopian tube, and this is the normal fallopian tube. You can see the cilia. Here you see the easiest thing. Does it remember high grade tubular adenoma or villous adenoma? So the epithelial stratification, loss of cilia, no mucin secreting cells, and apoptotic bodies. This is a very thick section. That's why you are not able to see any mitosis. Otherwise, you can see mitosis. This is the classic picture of stick. Okay, serous intratubular carcinoma, and that's most commonly associated with high-grade serous carcinoma. I am disappointed on my teaching. There all delegates are very good. I am not able to make them understand this more. Let us go to third one. This is the tumor. Yeah, you have to make the diagnosis, and then you have to answer. This tumor is associated with BRAF, TP53, BRCA, and CDK and 2A.
Launching the poll. Ten more seconds. Closing the poll. Sir, during the pre-poll, it was 42% for P53. Now it's increased to 57%. And the second one remains BRCA, that is 20%, and initially it was 24%.
Okay, let us go to the diagnosis. Is it epithelial or stromal or germ cell? It's epithelial. Is it invasive or non-invasive? It is invasive. Probably disease of low grade cytologically atypia, and you see a lot of somoma bodies. This is characteristic of low grade serous carcinoma. Okay, and as you know, low grade serous carcinoma is associated with BRAF mutation, whereas TP53 and CDKN2A mucinous and BRCA is a high grade serous. So this is a low grade. Probably the morphology is not very clear, but you look at the somoma bodies. Somoma bodies are very characteristically seen in low-grade serous carcinoma. High-grade serous carcinoma won't show this many somoma bodies, so this is associated with BRAF mutation.
Congratulations to 15% who got it right.
Yeah, I'm not happy, but again, this slide should all of them, 90% should get it. So this is the morphology, and what is the diagnosis?
Launching the poll now. Ten more seconds. Closing the polls. Now the response is 84%, which is for the option 3, which increased from 72% earlier.
So
that is
okay. So the answer is mesonephric. These are epithelial, invasive, and see the colloid-like secretions. Okay. If you see thyroid-like follicular carcinoma, like thyroid in the cervix or ovary, it is mesonephric-like adenocarcinoma. These colloid-like secretions is a clue for the mesonephric origin. Please remember, this can present as a remnant when it is in lobular pattern, hyperplastic when they are more in number, and the carcinoma when it is invading. So the last question, again I want at least 90% correct this time. Okay, this is the tumor. cystic spaces, solidness, fibrous bands. What is the tumor and what is its association?
Launching the poll. Five more seconds. Closing the polls. So in the first poll, it was divided with predominantly for option 3, that is 32%. Now it is 45%, that is option 4, associated with familial adenomatous polyposis.
Yes, this is a classic microcystic stromal tumor of the ovary, and as I showed the picture, beta catenin is nicely positive, and this is a part of extracolonic familial adenomatous polyposis. Super. With that, I think I will end my presentation. I love Steve Jobs, and he tells the one who are crazy enough to think that they can change the world are the one who do. Okay, I want all of you to get crazy and change the world for good. Thank you and have a great day. Thank you.